So yes, it's my pleasure now to introduce Dr. Anna Barker, or as I believe soon to be Associate Professor Anna Barker, to talk to us about preventing falls in a hospital setting. And I gave her a fuller introduction before, so thank you, Anna.
Well, thank you, Kathy, for the warm introduction, and thank you very much to the Sydney Organising Committee for what a fantastic event you've created here. The harbour view is just spectacular, and I can't wait to try out the Ferris wheel tonight and look at that view a bit further. I think that was a very moving presentation from Stephen, and I think brings home what we all know about falls, and that is the tremendous burden that they pose. And many of those falls that occurred in residential aged care will indeed end up as patients who then enter the acute setting, which is what I'm going to talk to you now about today. So I'm talking to you about the story of the Six Pack Project. Maybe just a show of hands, who's heard of the Six Pack Project in the audience? So that's good to see, because it's definitely taken up a lot of my time over the last 3 years, and I have given numerous presentations on the Six Pack Project already. But today I'm very excited to be able to share with you the findings of the Six Pack Project, and the highs and the lows. So first of all, I would like to acknowledge the substantial team that's contributed to this work. We've had wonderful input from the many investigators who are involved with Six Pack. Kathy and Terry are part of it, and many others here in the audience as well, Sandy Brewer, Keith Hill. It has been a big project, and we've needed a lot of hands on deck to do the work, and first and foremost the contribution of Renata Morello, who was the project manager for Six Pack, was really fundamental to the successful implementation of the trial, and of course acknowledging the NHMRC who funded the work. So another show of hands. The problem of falls in acute care. Is it solved? Hands up for yes. No, not one hand. Am I missing a hand up in the back there? Not one hand to be raised in terms of we've fixed the problem in acute care. So the problem of falls is definitely, in my perspective, remains unsolved in acute care. We did a very large amount of qualitative work in the baseline phase of the Six Pack trial that involved surveys with over 400 nurses, 24 key informant interviews across the 6 hospitals, and 24 focus groups with ward nurses. And it was overwhelming, the finding that all of those staff and stakeholders told us that the problem of falls in hospitals is far from solved, and indeed they rated it as their #1 patient safety issue that they're facing. When we surveyed the nurses, it was only half of nurses felt that their current falls prevention program was effective at reducing falls. And only 1 in 3 nurses really believed that falls actually could be prevented, and that really the majority felt that falls were inevitable. I guess it's not surprising then, when we look at the findings of the Cochrane review, that included trials in over 17 hospitals, and as Kathy flagged, a number of those coming from Australia and New Zealand, and it culminated to over 20,000 patients that were included in the Cochrane systematic review. However, there's no magic silver bullet in that systematic review. There's a statement that multifactorial programs may have an impact on falls, but typical of what we're seeing of so many Cochrane reviews these days, more trials are needed. So many of you would be aware of the trial led by Bob Cumming, and Kathy was involved, and Stephen as well, that was published back in 2008 and presented back at the 2008 ANZFPS conference, I think, maybe. And it was a great presentation by Bob Cumming, who spoke about the trial that involved a large number of hospitals in Sydney. And over a 3-month period, they implemented really, I guess, a best practice guideline model of care over a 3-month period, and unfortunately found that there was no effect above standard usual care with the implementation of the program. In terms of that, the problem of falls remains unsolved, as highlighted by that study where falls rates remained over 9 per 1,000 bed days. In terms of that study that it involved almost 4,000 patients, it was a great piece of work that really informed a lot of what we did with the six-pack trial. So, like many of you, I think I was on the search for the Holy Grail in terms of falls prevention in the hospital setting. We had the findings of the Cummings RCT, we had the Cochrane Review findings, and it was clear we needed a new solution. And I thought that we'd found that solution at the Northern Hospital. It was an outer metropolitan hospital in Melbourne, and probably typical of many hospitals that you have, an A2 level hospital. And at the Northern, they had developed the six-pack program, which is a simple falls prevention program that had been implemented back in 2002, and it was designed by Jeanette Kamar and many of the staff at the Northern Hospital after review of all of the evidence that was available and consultation with a number of falls prevention experts. They implemented the program and saw a wonderful reduction in fall-related injuries, and up to a 50% reduction in fall-related injuries was achieved. And impressively, an evaluation that I did in conjunction with the Northern Hospital was observed that that reduction in falls-related injuries was sustained for years and years and years, something that had never been published in the literature before. So that led to the six-pack project, which essentially was a three-phase project. It was conducted over a 3-year period and involved a baseline stage where we did a mapping of current falls prevention practice. We did a large amount of qualitative research of gathering information on knowledge and beliefs of the staff about falls prevention and how falls can be prevented in this setting. There was a large barrier and enabler assessment, including assessment of safety culture. And based on these activities, which involved the focus groups and key informant interviews that I spoke about before, we devised a tailored implementation strategy for the six-pack program, which is in the literature critical to successful implementation of programs. We then moved on to a 12-month RCT period where, in a classic RCT design, wards implemented the six-pack program, and half of the wards recruited continued on with standard usual care. In terms of the project, we recruited 6 hospitals across New South Wales and Victoria to participate in the trial, and overall 24 acute medical and surgical wards were included in the project. Wards were nominated by hospitals, and they were ones that were the hospitals nominated as having a problem with falls. Could have been many hospitals and wards that could have therefore been eligible to participate. The other criteria that we set forward was that they utilised a low number of the six-pack strategies already in usual care, so that we could hopefully then be able to create a difference in terms of practice to hopefully impact on falls injuries, as we had seen in the observational pilot study. Following that, we then had a 12-month period of sustainability where, after the trial, we wanted to see what happened. So did practice change or changes that we'd achieved in the RCT, were they sustained over time? And the outcomes, did they also stay the same over time? So what is the six-pack? Those of you who've heard me present before and they go flyaway lines of, is it about improving your core stability to prevent falls? Is it about reducing alcohol consumption to prevent falls? And no, it's not. It actually is something that's probably very common to many of the characteristics of the falls prevention programs you're using in the hospital setting. There's falls alert signs above the patient bed, low beds, bed chair alarms, gait aid positioned within reach. Interesting to hear the conversation about the paradox that we may face in terms of having an aid accessible and close, but then creating a cluttered environment. Using toileting schedules, we know that many falls are related to toileting, and supervision in the bathroom, because we know that many falls occur while people are unsupervised in the bathroom. So just a quick show of hands, who uses falls risk alert signs in their hospital setting as a falls prevention strategy? Yep, or tool. And what about low beds or high-low beds? Yep. And bed chair alarms? Yep, quite frequently used. And the other ones are pretty common, what you might almost classify as standard usual care strategies. The aim with the six-pack, though, was essentially a concept of a care bundle, where we focused on a small number of targeted interventions in the aim that hopefully then there'd be greater uptake and implementation of these interventions. Importantly, we used a risk tool that had been developed and validated at the Northern Hospital and published validation with shown to be predictive of fallers at the Northern Hospital. And also the integration of checkboxes for the 6 strategies which nurses were required to complete each nursing shift. And this was thought to be a critical factor to the success of the program at the Northern Hospital, the fact that the processes were integrated into usual workflow for the nurses. In terms of the implementation, it was supported by a site clinical leader that was nominated by the Director of Nursing at each hospital, and they were the person that was responsible then for delivering the education and training to the ward nurses on use of the six-pack program and overseeing its use over the course of RCT and troubleshooting issues that we knew would arise. The six-pack site clinical leader was supported by the six-pack program facilitator, which was Jeanette Kamar, who was the person who developed and implemented the program at the Northern Hospital. We also had a project change management facilitator who also worked with the site clinical leader in the hospitals to achieve practice change through numerous different behaviour change strategies. We then also had 2 champions on each intervention ward that also then supported the frontline staff in the implementation of the six-pack. There was extensive education that was provided to the site clinical leaders, to the champions and to the ward staff. There were numerous site visits that occurred throughout the 12-month course of the project. There was a big focus on the use of audit reminders and feedback. Each month there was a meeting with all of the site clinical leaders across the 6 hospitals where we would review falls data, practice audit data. We had data collectors on the ward every day of the RCT trial and the baseline phase collecting process data on the use and uptake of falls prevention strategies and their delivery at the patient's bedside. And that data was fed back to sites and wards throughout the trial on a monthly basis. We collected falls data via multiple sources. We audited the medical records every day for patients that were on the wards looking for evidence of falls. We spoke to the nurse unit manager every day and asked if there'd been any falls in the last 24 hours. And we also audited the hospital incident reporting system and administrative data for evidence of falls. Those who've heard me present previously will know that only just over half of falls actually make it into the incident reporting system, and hence the need for having such a comprehensive method for capturing falls data. So, what did we find? Our characteristics of our cohort in baseline, I think, are quite typical of your general medical surgical wards that you'll find in acute care. Patients aged over 60, roughly equal males and females, and a length of stay of around 4 days, so quickly in and quickly out. In terms of falls in the baseline period, we had almost 400 falls and just over 100 fall injuries. In terms of our RCT period, we found that we had over 30,000 patients that were involved in the six-pack trial. Due to the cluster randomised design, every patient admitted to the participating wards was included in the study. And this was over 40,000 patient ward admissions that were included in the six-pack randomised control trial. Demographic characteristics were very comparable to the baseline cohort, and there were no significant differences in patient characteristics that we could identify between the intervention and control wards or in other key outcomes such as length of stay. In terms of the six-pack data set for the RCT, we had data on over 1,000 falls and over 600 falls injuries that were included in the analysis. This slide here shows you one of the data on one of our key indicators related to the six-pack implementation. And that was the requirement that every patient that was identified as high falls risk was required to have an alert sign placed above their bed and at least one other strategy that was in place. And you see at the start of the trial that the practice on or achievement of this KPI was very low on the left-hand side and also very variable across wards. And as we move throughout the 12-month RCT period, you see that the practice improved and trended upwards in all wards, and we had less variability in practice, which is a key component of quality, improving quality of care, and that it increased in all wards over time. When these slides that I'm going to present to you now have some graphs of data that relates to the baseline period in terms of practice or process measures and outcome data in terms of our falls. So to the left of the red line, you see the baseline data from our 3 months data collection before the RCT was initiated, and then the 12 months following in the RCT period. The blue line represents the intervention wards or the six-pack wards, and the green line the control and usual care wards. You see with risk assessment completion, we had a fantastic improvement in the completion of the risk assessment that occurred quite quickly after the program was implemented and continued to increase throughout the trial period. We see that that was much higher in terms of the rate of risk assessment completion per 1,000 occupied bed days on the control wards with the green line. In terms of the falls risk alert sign, we see a very similar picture. We've got a great improvement from baseline, happens quickly and early on, and it's definitely a great improvement compared to what was happening on our control wards. When we look at gate aid within reach, which was another one of the six-pack strategies, it's a little bit less pronounced, the difference. We definitely had a higher use of this strategy on the six-pack wards, but it wasn't nearly as dramatic as what we saw with the other strategies presented so far. And a key factor in this that the nurses told us along the way in the focus groups, interviews and surveys and our site visits, there's just not enough gate aids in acute hospitals for all patients that need them. Patients are sharing gate aids within a room, and there's also this conflict that was raised earlier about do you position the gate aid close by so that the patient can reach it, or does that create a cluttered environment that then poses a hazard to the individual? In terms of the use of bed chair alarms, again, we didn't see quite as big a difference between the wards. It was still bigger on the intervention wards and very up and down, and I guess that's reflective of this is a strategy that's used infrequently or sporadically. It's not one that would be in place all of the time on the wards. In terms of low beds, participation in this trial required that the hospitals purchase a number of low beds and bed chair alarms for the intervention wards, as we were aware that resources were a critical factor in terms of being able to implement these strategies properly. You see, again, a great dose effect in terms of the use of low beds on the intervention compared to the control wards, and a great change from baseline over the course of the RCT. And whilst there's some improvements in the control wards, which may suggest a small degree of contamination, ultimately the dose was far higher in the intervention wards. However, this slide here shows you a graph of fall-related injuries from bed falls. Despite having that wonderful increase of dose of use of the six-pack strategy of a low bed, we see absolutely no difference in fall-related injuries over the course of the RCT from baseline to the end of the RCT and between control and intervention wards. Why is it so? I don't know. But there is a couple of things that come to mind. Most notably, there's been a number of randomised control trials, high quality, large-scale trials that have now been published that show similar findings to this, that maybe low beds don't work in terms of reducing fall injuries. Is it because the beds are not applied to the right patients who need them most? So is it an issue about targeting the intervention to those that would benefit from it most? Or is it an issue surrounding the quality of the intervention delivery? Were the low beds actually lowered to the lowest level when they needed to be? When we look at bathroom supervision, this relies on data coming from documented use of this strategy. So it's not ideal, but it's what we have. And when we look at this, we see from documentation, it appears that the use of this strategy greatly increased in intervention compared to control wards and from baseline. However, we saw no change in the rate of bathroom falls over the course of the RCT. They remained stable throughout the period from baseline to RCT, and no difference between intervention and control wards. Why is it so? I don't know. But it could be that maybe it was being documented but not implemented. Maybe it was happening, but maybe the dose wasn't sufficient enough to impact on the outcomes of fall injuries and falls. When we look at unwitnessed falls in the bathroom, no change. When we look at the documentation of the use of the strategy of a toileting schedule, so part of the six-pack was if a patient is perceived by the patient's treating nurse to need especially frequent toileting, then the nurse documents the frequency of toileting that the patient should have, 2 hourly, 3 hourly, hourly, that the nurse then is responsible for checking on the patient and then taking them to the toilet as required, in an effort to try and reduce the patients from getting up and trying to go on their own if they were perceived to be at risk of falling. Similar picture, no change. When we look at the overall dose of the six-pack, it was good. We got a 3- to 4-fold increase in the use of six-pack strategies on intervention compared to control wards, and it happened pretty quickly. Mind you, there were a number of resources that went into achieving that practice change. Six-pack program facilitator, six-pack change management facilitator, site clinical leaders, ward champions, over 30 site visits, 12 monthly meetings with all of the site clinical leaders, reports going out to hospitals and wards every month on real-time data on their falls, on their use of six-pack strategies, more than what would be feasible in everyday usual care. Not surprisingly then, when I present this slide of the change in falls over time from baseline to RCT and the difference between the falls in the control and intervention wards, there was no effect. We had the same result as Bob's trial, absolutely no effect on falls. No real effect on injurious falls. I squint at this data and I wonder, in the last 6 months, are we seeing a decline? But then you have similar noisy patterns in the data early on, and it's something we can look at, but I'm not confident that really there is something going on, and we see the same in the control wards. And our falls injuries are a very similar picture, and again, no significant effect in terms of the difference between the rate of falls injuries between intervention and control wards. When we look at the wards that were included in the six-pack project, there was a large amount of variability in the rates of falls and falls injuries, very typical to what we have out there in usual care and representative of our hospitals. And that heterogeneity, it does pose some problems in terms of design and power for trials, but really it's something that we had considered in the analysis, and I think adequately we were powered to detect differences if they were there. In terms of exploring the reason for no effect, there's several things I guess we have to consider. Was the problem fixed? We had nothing to change. I think the data on that previous slide really shows that that's not the case. There's some wards that had rates of falls close to 20 per 1,000 bed days. Falls injuries up around the 5 per 1,000 bed days. This problem is far from fixed. Not equivalent groups, maybe they were different. From the data that we had, we could find no difference between the groups in terms of measured variables known to impact on falls, such as cognitive impairment, admissions from nursing home, age. Admittedly, we relied on administrative data from hospitals. It's not the ideal source of data collection, so maybe there were things that were different across the wards that we didn't measure and didn't capture. But from all indications of what we had, there was no evidence of a difference between the groups in terms of their characteristics. I think the slides that I've shown you is we didn't have implementation failure. This trial is one of the first trials to provide such comprehensive data, not just on the outcomes, but how did practice change alongside those outcomes that we were observing. When we look at power, the original power calculation for the six-pack trial was based on a sample size of 16,500 patients and 510 fall injuries. We had over 30,000 patients and over 600 fall injuries, and there was no evidence that we were underpowered with this study. In terms of contamination, maybe a minor effect, but I don't think it was a main factor that really explains our finding of no effect. So was the intervention ineffective? The intervention may well have been ineffective, but we don't know the answer to that. The intervention includes, as I highlighted, a number of strategies that subsequent randomised control trials have found to be ineffective in our single intervention studies, and that is low beds and bed chair alarms. Also, the six-pack program didn't include anything on the prevention and management of delirium, probably our number one risk factor for falling in the acute setting. And so maybe we just missed the target in terms of really honing in and targeting that problem of preventing delirium. No effect does not mean no effect on falls and falls injuries. No effect means that it had the same effects as standard care in terms of falls and falls injuries. What you did see is that there has, with implementation of the six-pack program, we got a great improvement in practice. We got standardisation of practice, which we know is improvement of quality of care. The wards that implemented the six-pack program loved it. They thought it was much better than their current falls prevention program, quicker, easier, simpler, and the face validity of the program, they believed in it. Also, I guess we cannot ignore the fact that maybe the six-pack program is as ineffective as current standard usual care in terms of its impact on falls and falls-related injuries. One finding that was interesting. The focus groups with nurses told us that the number one thing that they felt prevented falls was specials. Having a patient constant observer next to the patient was the only way that you could prevent falls. The six-pack program didn't include specials, nor did it include an instruction to remove specials or get rid of specials. And what we see with that blue line there in terms of the intervention wards is that there was a steady decline in the use of specials on the intervention wards throughout the course of the RCT. And in the control wards, it was a little bit noisy, but remained relatively constant. And this is interesting and something we will be exploring further. In terms of the design of this trial, it really was a high-quality trial. It's the world's biggest ever falls prevention trial that has ever been conducted. We had rigorous design in terms of a multi-centre trial that really provides evidence of this generalisability translation. It really was an incredibly large sample, and it was a pragmatic design. And by that, we used real-life staff to implement the program. They were heavily supported by a project support team, but ultimately the delivery was done and integrated as part of usual care. And that tells us a lot then about the acceptability and feasibility of falls prevention in the hospital setting and what doses you might be able to achieve in a real life example. In terms of the design, it was also a hybrid design where we had a lot of data regarding implementation and a very detailed program evaluation that occurred alongside this RCT. We also had the pilot study, which gave us a lot of learnings that we then could apply to the RCT. So in terms of what we have found in terms of the six-pack trial, there are some limitations that we must acknowledge. The hospitals that were included in the trial, they were sampled by convenience. They put up their hand to participate in this project. They may not be representative of all of the other hospitals out there in Australia, but they may not be unique. In terms of our data collection, it was non-blinded, the data collection of our data on the use of six-pack strategies, so there could have created some bias there. All of our outcomes in terms of falls and falls injuries were coded by a secondary data collector who was blinded to ward allocation. And we really didn't capture any data, I guess, on the quality and the appropriateness of the delivery of the interventions. We have information on dose, but we do not have information about whether or not the interventions went to the right people. So what did we find out? I think we might still be searching for the Holy Grail in terms of falls prevention in the acute hospital setting. When we go back to where we started this talk with the Cochrane Review, there was no magic silver bullet in the Cochrane Review, and there is no magic silver bullet in the six-pack trial either. What we did see, though, is that the number of patients that are included in the six-pack trial was more than is included in the Cochrane Systematic Review. So in summary, what did we find? We found that falls remain a problem still in acute hospital wards. We were able to change practice in a meaningful way regarding falls prevention in the acute hospital setting. But we had no impact on falls or falls injuries above that achieved with standard usual care with implementation of the six-pack. However, as we are still searching for the Holy Grail, we need to think about some where to from here. And I think I encourage you all to reflect on the very, very crowded landscape that we have in hospitals. And this may not be unique to hospitals, it may occur in residential aged care as well, and it may occur in the community setting, but it is a very, very crowded landscape that we are operating on. Hospitals are incredibly complex systems, and older people that are presenting to hospital have very complex care needs. And in terms of falls, it's a very complex problem, and complex problems cannot be solved with simple solutions. So it's just the start of the journey in terms of telling you about the findings we had from the six-pack trial. Later on today, we have a presentation from Sherelle from our research team who will be presenting on some information about falls injury epidemiology, drilling down to the where and why people are falling in the acute hospital setting. We then also have a study by Renata Morello who's presenting on what is the real cost in Australian dollars, in current dollars, for a fall or a fall injury that has occurred in hospital. Renata will also explore in another presentation these issues surrounding implementation fidelity. How do you get practice to change? Thank you.
So thank you very much, Anna, and congratulations on leading such a massive, complex project so well and presenting it so clearly. And yeah, thank you very much.
Sorry, I don't have the magic silver bullet.